Thanks so much for the introduction, and thank you so much for this opportunity to be able to share our research experience. So can everybody see the slide? Okay,
Yes, you're good.
awesome. Thank you. I wanted to show this picture because this is the view from our window. I wanted to share with you where I am located. This is my quick disclosure. What's in Abbotsford? We have Castle Fun Park and lots of blueberry farm. And this is our backyard. So we do have really nice nature and garden. And I heard that one person from our I suppose, center said, before I came to Abbotsford, I didn't know where Abbotsford was existed. So, and I think that's the same for me as well. It's about 50 kilometers drive from Vancouver, serving a population of approximately 400,000. And we have the fastest growing cancer population in BC. So it poses a really interesting challenge in terms of both the clinical and research environment in our site. I do serve in 3 tumor sites: gynae, geo, and lung cancers. So my tumor sites are pretty spread out. I think when I came to Abbotsford to engage in research, my interest was really cancer care in everyday life. In the principles of quality improvement, what can I do to make changes in immediate things that I can see in my clinic and my practice and my patients? So there are foundations and pillars of, I guess, cancer care principles that I consider that are really important, and they may be fairly spread out. And I have to say that they're as spread out as what my tumor sites may look like. But I think there is definitely a unique place in sort of clinical sense that this sort of real world cancer care research can bring about. So of the 6 pillars, there are various projects that I have been engaged in the past and right now that are fairly spread far apart, but they all come together to have hopefully patient-centered care. So I am engaged in clinical trials and real-world databases, of which are actually several, of which we will talk about a couple of them today. Also, a project called Optical Probe and education, palliative care, survivorship, quality of life, and economics of care. So some of these topics, especially in the realm of therapeutics and quality of life, I am going to discuss a bit further today in our presentation. In terms of therapeutics, I think the biggest thing that we are faced with, especially in gynae cancer, is stratification of risk and treatment. So what to do and how to predict what's going to happen to the patients. And that's very, very challenging. And we have used clinical indicators, genomic indicators. Now we are starting to use immunologic indicators, and metabolomic may come in the future. Somebody told me that metabolomics are what used to be immunologic treatments in cancer care 10, 20 years ago. So I think that's very exciting. But in the meantime, it requires significant research and investment. And we're really lucky to be in BC to basically be with really well-renowned physicians, Dr. McAlpine, Dr. Kwan's team, and the scientists who have really looked into these issues in great details. So in the topic of endometrial cancer, this was actually a topic that was really interesting even back when I was training in Calgary, because as I was coming to BC from Calgary, I noticed that there was a fair bit of discrepancy in what we do, and I realized that the evidence in this particular field, especially in early cancer, was really quite difficult to pin down. And we have traditionally relied on lots of clinical factors to gauge where the patient risk would be. So we have published some papers and presented at different conferences for stage 3. So this one, and this is a poster from 2017, and was able to figure out what may be some of the impact of adjuvant management and risk factors on survival in FIGO stage 3 endometrial cancer patients. I won't go into the details too far, but just wanted to mention that even though there is no level 1 evidence to suggest that radiation therapy may improve quote unquote overall survival in this particular stage, we really think after pulling the 2 provinces data together that radiation is really a key integral part that needs to be considered in management of stage 3 cancer. So that was really quite reassuring to see. Stage 1 has also been very difficult area of topic that does not have a lot of obvious evidence, just specifically focused on this particular stage. So we had posters in the past to demonstrate some of the data, but we did have an opportunity to be on the plenary session for our multi-provincial data to talk about this particular topic, and really proud to introduce our fellows, Rachel and Joni, who Joni was kind enough to join us today to present the data that we presented at SGO 2021 plenary. So I'll hand it over to Joni.
Cool. So thanks very much for the opportunity to come and talk a little bit about what we've done here with high-risk stage 1 endometrial cancer patients in a trans-provincial collaboration. So I'll talk a little bit about our adjuvant chemotherapy and radiation for patients with high-risk stage 1 endometrial cancer treated with curative intent surgery and its impact on recurrence and survival. And I have no disclosures. So as a way of background, and something that we all know quite well, there's been multiple prospective studies looking at the role of chemotherapy and radiation in the treatment of high-risk early-stage endometrial cancer, but with varying results. The results from the use of chemotherapy have been especially mixed. So just as a way of a few examples, GOG 249 explored the use of vaginal brachytherapy followed by 3 cycles of carboplatin paclitaxel, chemotherapy in combination with radiation alone, in comparison with radiation alone for stage 1 and 2 serous or clear cell tumors. And the study demonstrated no overall survival or recurrence-free survival benefit. There was some critique that potentially more chemotherapy might be required to show a benefit in this group. PORTEC-3, a larger trial, did include high-risk stage 1 disease, but as well as higher stage disease, and they compared chemotherapy against radiotherapy, followed by chemotherapy against radiotherapy alone, and finding that the chemoradiotherapy arm followed by chemotherapy had a better progression-free survival and overall survival profile in serous and stage 3 disease in their post-hoc survival analysis. And then in the combined NSGO, EORTC, Mango-Iliad trials, they did include stage 1, 2, 3 disease of all histology and compared 3 to 4 cycles of chemotherapy with radiotherapy against radiotherapy alone, and found an improved progression-free survival, disease-specific survival, and trend to overall survival in high-risk stage 1, occult stage 2, and stage 3 disease. But what we're left with is a bit of a lack of level 1 evidence in the setting of high-risk stage 1 disease. These trials include smaller numbers of stage 1 patients, heterogeneous altogether, including higher stage patients and histologies, and leaving us with the question of what's the optimal treatment for stage 1 high-risk endometrial cancer patients. So this retrospective study was performed to help shed a little bit more light on that, as well as better understand the treatment patterns and outcomes for patients with high-risk early stage endometrial carcinoma. So we included 8 cancer centers in Alberta and British Columbia, including patients between the years of 2000 and 2010. And patients were included if they were treated with curative intent surgery and had a high-risk early stage disease, which was defined for us as stage 1B grade 3 endometrioid histology, or any myoinvasive non-endometrioid histology but confined to the uterus. BC Cancer's guidelines recommend, in general, 3 cycles of chemotherapy plus radiation in selected patients, while the Alberta guidelines suggest radiation for high-risk patients, but with no strong recommendations for chemotherapy in this group. Data that we collected included the age of diagnosis, pathology, including the histology and LVSI status of the tumor, FIGO stage as determined by surgical resection, and surgical factors were also collected, including lymph node dissection, appendectomy, omentectomy, etc. Adjuvant treatment specifics were collected, including radiation delivered and mode of delivery, chemotherapy administered along with number of cycles received, and then patient outcomes collected. And we were most interested in recurrence, location of recurrence, overall survival, disease-specific survival, and recurrence-free survival in this group. Survival analysis was conducted using Cox proportional hazards regression and log rank test, and survival curves were estimated using the Kaplan-Meier method. So on to the results that we found. So amongst our patients, the patient and disease characteristics noted, so we had a total of 414 patients that met our high-risk stage 1 disease category. These patients had a median age of 65, but with a range between 33 and 91 years of age. The majority of the patients were non-endometrioid subtypes or mixed, and were stage 1A as the majority. Nearly 60% of patients did have a pelvic lymph node dissection as part of their surgical staging, and 8% had a periaortic lymph node dissection. 35% of patients had LVSI positive tumors. In terms of treatment, 56% of patients had radiation therapy and 37% of patients had radiotherapy alone. And this was split rather evenly between vaginal brachytherapy and combined external beam and vaginal brachytherapy. Nearly 25% of patients had chemotherapy delivered as part of their treatment, and most received 4 cycles or less. And about 5% of patients had chemotherapy alone. Approximately 30% of patients passed away during the follow-up period, and this was split evenly amongst the non-endometrioid subtypes and the deeply invasive grade 3 endometrioid disease. So what I'll present next is our look at our Kaplan-Meier survival curves and as their association with various treatments received. So as you can see in these Kaplan-Meier curves, we did not find a statistically significant improvement in terms of overall survival in the high-risk group of the 414 patients altogether, with chemotherapy with a relative risk of 0.7 and a p-value of 0.13. And this was also seen in terms of disease-specific survival, with chemotherapy not associated with an improvement, with a relative risk of 1.06 and a p-value of 0.84 within this total group altogether. What we did see, however, in recurrence-free survival, when we looked at the association with chemotherapy, is there was a noted improvement. The relative risk was 0.61 and a significant p-value noted here with 0.03. And this translated into a 1.6-year benefit with adjuvant chemotherapy in the whole high-risk group as a whole. As there's been, as alluded to previously, some controversy about the number of cycles if it were to be delivered in terms of chemotherapy, we did look at the association with the number of cycles of chemotherapy received, so 4 or less, or 5 to 6, and if it was associated with any differences. And we found that there was no difference in disease-specific survival with the numbers of cycles with recurrence risk of 0.83 and a relative risk, of 0.83 and a p-value of 0.79 for increased number of cycles. And this was similar for overall survival with a non-significant association. Additionally, increased chemotherapy was not associated with a recurrence-free survival benefit with a non-significant p-value noted and a relative risk of 1.1. As can seen in this last Kaplan-Meier curve. We did also look at radiation, the benefit of associated radiation. And the association radiation had with overall survival, disease-specific survival, and recurrence-free survival. And there was no significant benefit seen in this association. And this was also performed in the FIGO grade 3 stage 1B subgroup, which I'll talk a little bit more to, and the similar results were found where we didn't find a significant associated benefit. So as mentioned, we did pull out the subgroup of stage 1B grade 3 patients to determine if there was any positive associations with chemotherapy. In this subgroup, there were 60 patients. And similar to the larger group, we found no association with adjuvant chemotherapy and a positive overall survival benefit with a relative risk of 0.82 and with a non-significant p-value. The association of chemotherapy with recurrence-free survival was also lost in this group with a relative risk of 0.65 and a p-value of 0.5. And additionally, not pictured in this slide, chemotherapy had a non-statistically significant association with disease-specific survival. When we looked at recurrence-free survival in association with adjuvant radiotherapy, and you can see split on the left, the whole group as a whole, and then the stage 1B grade 3 group on the right, there was a trend towards significance with the addition of radiotherapy in the high-risk group, and this is for recurrence-free survival, with a relative risk of 0.73 and a p-value trending to significance at 0.07, but not meeting it. When the deeply invasive FIGO grade 3 group was looked at, we did not see this association here. So we went and we looked at a few other things that have been done, similar studies, retrospective studies, and in particular looking at comparisons to a similar study done by Vancouver a few years ago as well, comparing their group and the treatment for stage 1B or stage 2 high-grade endometrial subtypes, and compare this with a group in the Netherlands. And so they retrospectively analyzed their treatment strategy, which was focused more on surgical staging and radiotherapy, along with 3 cycles of chemotherapy, versus the group in the Netherlands that focused more on limited surgical staging, radiotherapy, and a limited use of chemotherapy. And their results found that chemotherapy combined with radiotherapy was associated with statistically significant benefit in progression-free survival and overall survival. And you can see that noted there in the Kaplan-Meier curves. And so we were sort of left wondering, why are we seeing different results, particularly in our 1B grade 3 group? And Rayner's included stage 2 patients, and we wondered if this potentially may contribute to some differences there. Is it possible that stage 2 patients represent a significantly different risk that benefits more from chemotherapy than stage 1B alone? And our study followed patients out for a bit longer, and potentially there's some loss of the overall survival benefit over time. And our study, including this group there, was slightly smaller than the Rayner's et al. Study. So it's a possibility our power was certainly a little bit less in that group. But we ultimately were left wondering, does it really come down to molecular subtypes? So we know from PORTEC-3 molecular subtype analysis study of that study that there was significant improvement in recurrence-free survival and overall survival for patients with p53 abnormal tumors when they received chemo-RT over RT alone. And that in MMR deficient patients, they didn't have an improvement with the addition of chemotherapy. So the differences, POLE mutations, of course, did well regardless, and the non-specific mutational profile trended towards improvement with chemo-RT, but was not very well defined. So the differences in our studies and other retrospective studies, differences may be more reasonably down to the included molecular subtypes, and neither our study nor other previous retrospective studies like this had access to these data. And so it's certainly possible that stage 2 patients of the same histotypes may include more patients with p53 mutations potentially in their tumors, or may garner more benefit from chemotherapy. And we can't know either how many patients were included that had POLE mutation or a non-specific mutational profile as well. So in conclusion, our retrospective review demonstrated the addition of adjuvant chemotherapy or radiation therapy didn't show an overall survival benefit in high-risk stage 1 endometrial carcinoma. We did find that adjuvant chemotherapy was associated with an improvement in recurrence-free survival for the high-risk group, but not for the stage 1B grade 3 endometrioid carcinoma subgroup. When we compare with similar studies, I think we've learned more than anything else that FIGO stage and grade, and we're learning more and more, are only an imperfect surrogate marker for outcomes when compared to molecular subtyping, and that we've been making decisions based on clinical information in the past, and which we now know to be likely incomplete information. So we're certainly hopeful that in future results of the Rainbow trial, PORTEC-4A and TAPER will bring a bit more clarity to treating these patients, and in the meantime, being cognizant not to overtreat these patients in the future. So thank you very much. I'll just stop sharing my slides here.
Again, Joni, thank you so much for presenting the data. And I think I totally agree with Joni's comment that really the genomics and molecular classification is where it's at in terms of the next step in where we need to go to really tailor the patient, tailor the treatment to the patient. And I just wanted to briefly talk about another research project that I did with medical student Christine, and it was presented at the UBC OBS-GYN Student Research Day, and really thankful for the panel, and also Christine, the patient, the Christine had the best presentation for student award that day, so she was really excited. And this is about the cervical cancer patients outcome in BC. So according to our 2018 staging system, we know that patients generally do really quite well, but as the stage goes up, their outcomes unfortunately still go down, and we're still unable to exactly know what to do when the patient recurs, and what the best treatment sequences would be in some of these patients. So about 12% of patients of cervical cancer in BC end up being stage 4, and the chemo rads usually induce really excellent response, but there are definitely a number of patients who, despite young age and initial good response, ends up with metastatic disease. Larger tumors, higher histology, older age, and lymphovascular invasion all seem to contribute to this kind of risk. And P16 positivity association with HPV infection, they are kind of inconsistent in terms of whether that acts as a risk factor. And if patient does recur, we do have the first line therapy of chemo and bevacizumab, and nowadays we also consider immunotherapy such as cemiplimab for next line therapy, but really the treatment options do end up being quite limited. So we performed retrospective chart review. It was another really quite large study with 780 patients between January 2010 and December 2017 with cervical cancer patients in BC was performed, and we collected patient disease and treatment characteristics, and the outcomes were analyzed afterwards. So just to summarize it really quickly, increased survival was associated with surgical resection, use of brachytherapy in addition to external beam radiation, use of cervical concurrent chemotherapy, and use of cisplatin therapy compared with other regimens. I don't think there's any surprise here. Good to know that that's the case in our province, but these are sort of known facts that we have seen from other studies. P16 negativity was associated with poorer survival, definitely in all measured parameters in our study. So as far as we can tell, that does seem to be a fairly poor risk factor. And peri-radiation therapy chemotherapy was not associated with increased survival outcomes in our patients who received it in adenocarcinoma and adenosquamous histology. So this is the general characteristics of these patients. The P16 negative patients were actually very small in percentage, but most of them did not have obvious P16 testing done. And there are a proportion of patients who received either primary resection, so about 19%, and clearing hysterectomy, which is about 5%. And many of them received radical radiation therapy, about 82%. And most of them had concurrent chemotherapy, about 85%. So we, for all of these retrospective data, not only OS and PFS, we always try and include cancer-specific survival to reduce some of the possible confounders. And again, as you can see, the cancer-specific survival as well as overall survival and PFS are actually really quite different between the P16 positive and negative. And unknown had somewhere in between, which probably indicates that some of them are P16 positive and some of them are P16 negative. So at least in our database, seem to be one of the risk factors. And of course, the radiotherapy, especially with people who had radiation and brachytherapy, one may argue, well, then maybe people who had brachytherapy are just better patients. But you can see even just in terms of cancer-specific survival, so we don't count any of the non-cancer-related death in that particular count, patients did have a better outcome in that case, and concurrent radiation therapy and chemotherapy regimen. And this really is something that we wanted to show, that patients who receive chemotherapy around the time of radiation, either before or after. And we do that not necessarily on level 1 evidence, but sort of because there are some smaller studies that showed possible benefit. We so far in our cohort did not see any benefit with that. So that's what happens to our earlier stage patients who receive radical treatment over time. And we have survival time and follow-up up to about 12 months, 120 months by median. And that's the P16 graph, where the P16 positivity and P16 negativity are clearly separated, and the rest are kind of unknown. So we actually don't know exactly what to do with this particular group, but certainly the drop off of the P16 negative population seems to be really, really rapid in the first 1 to 2 years. And not surprisingly, patients who have had smoking history and currently still smoking or former smoking seems to have poorer outcome. And the size is very much an indicator of poor response or poor outcomes, LBI. And in terms of the histology, I found this really, really fascinating too, that there was actually no difference between the adenocarcinoma and squamous cell survival up to 10 years there. These two curves actually are identical. So we always think adenocarcinoma patients have poor chances of survival, at least in our cohort, which is actually fairly large. It seems to be that they're pretty similar. Basal cell, undifferentiated MMMT, all these other more rare subtypes, of course, do have poor outcomes. And this is related to radiation. I'll just skip this slide. I wanted to show a couple of things that are pretty fascinating. That, for example, surgical resection that is relevant, done for the patients who have stage 1 cancer seems to be associated with better outcomes. But as it goes to stage 2, 3, and 4, actually the correlation is not really there. So reassures us that it is actually a good thing to do concurrent chemoradiation therapy right away in these patients. And this is estimation, again, sort of like the counterpart to the slide before. Patients who have stage 1 disease, and we included only stage 1B, the radical radiation therapy may or may not make a big difference in this particular group. It maybe is underpowered to really show a difference that previous prospective studies showed with adjuvant radiation therapy. But as it goes with stage 2, 3, and 4, the radiation is definitely a modality that will improve our patient's outcome. And again, by the same token, in stage 1, really whether they get brachytherapy or not doesn't seem to matter much, but that does matter hugely as we go through stage 2, 3, 4. I didn't show it here, but the cancer-specific survival and RFS all match sort of the same pattern. And then concurrent chemo too, if patients didn't receive cisplatin with the radiation at stage 1, didn't really seem to matter whether we added or not. But when we go to stage 2, 3, 4, it's a big, big difference. So that really does make a difference. Patients who are not able to do all 5 weeks of chemotherapy when they get the chemo radiation therapy does seem to do poorly. And it's not just overall survival, cancer specific and recurrence-free survival also is different. So being able to not just quote unquote delaying because patient has some GFR issues or something, but being able to deliver the chemo on time all of the weeks is actually really, really crucial. And that same thing was also shown for dose reduction as well. So that is very, very interesting. So this is, I think, in my opinion, one of the most interesting data that shows, if anything, people who got chemo therapy around the time of radiation actually numerically has more events than people who didn't. And this is only adeno or adenosquamous carcinoma specifically. And they didn't seem to have any benefit from the carbotax that we give before or after radiation therapy. So maybe I'll talk about it in a second, but we need to reevaluate that particular policy we have. So for the rest of the ladies who had recurrent or metastatic disease, we see that there's about 13% who has upfront incurable disease. So very much similar to what we saw in the previous BC data and through the cancer statistics. And about 23% end up with the recurrent disease. And even though we may say, oh, majority gets cured, this is still a fairly significant number that becomes a problem once they have recurrent disease. They have terrible pain, especially in the pelvis, very bad disease that and their outcomes very poor. So we still don't have really a good solution to really help them with. And there are some patients who ended up having some surgery, and majority went for systemic therapy. But you can see that half of the patients actually don't receive any systemic therapy, unfortunately, and they pass away from their disease. I think that carboplatin, paclitaxel, bevacizumab really should be offered as upfront therapy in most of these patients, but a lot of patients end up not being able to receive bevacizumab, and they end up just getting chemotherapy. And the differences between this red and green curves are actually statistically significant as well. The second line treatments are really all over the place, and we're hoping and expecting that we are able to access immunotherapy pretty soon in the future. I am going to just pause here for a second and just read the comments to make sure that I don't pass up any questions. All right. So stage 1 cervical patients who have surgery are enriched with those with earlier stage, smaller disease than stage 1. Patients who do not have surgery, therefore not really comparable group. Yeah, and that's a really, really good point. Even though we did our best to just select for the stage 1B, instead of all stage 1 in our specific group. So we actually excluded all the stage 1As. I think definitely we could be comparing apples to oranges. So we probably need to deep dive the data a little bit and ensure that that's not the case. I will move on to the next few slides, almost towards the end there. And please just interrupt me with any questions if there are any. So bevacizumab, I just wanted to touch upon this because this is a GCI round, and we are really, really grateful to GCI trial group for funding this study. The title is Bevacizumab Dose, randomized phase 2 study of 2 doses of bevacizumab combined with single agent chemotherapy in patients with platinum resistant and refractory ovarian cancer. So this study has not been recruiting yet, but it will probably starting this summer because it has gone through all the hoops and ethics at this point. So the treatment schema is all patients with ovarian cancer eligible for chemotherapy plus bevacizumab because they have recurrent platinum resistant or refractory ovarian cancer and no contraindication to bevacizumab will be stratified 1-to-1 to the current dosing, which is fairly high doses of bevacizumab, 10 or 15 milligram per kilogram, depending on the schedule, versus half of that, which is lower standard, which most of other tumor groups use in their regimen. And this idea really came from the fact that for whatever reason that is unbeknownst to us, our gynae cervical and in this particular setting, the resistant ovarian cancer, seems to use the higher end of the bevacizumab dose versus the lower. And really the question is it really true that higher doses of bevacizumab is more effective than lower, or are we just using it just because, you know, the level 1 evidence tells us that that's the dose that they used? And it's meant to be a really practical, a real world, pragmatic study that collects as little data as possible, just only the ones that we really need to focus on. But we try to include a lot of different data points, including quality of life and some correlatives. The correlatives are still in the works, but most of the shaping of the trial has been done. So we are hoping to, again, recruit the patients to our study and initiate the trial in Vancouver, Abbotsford, and other centers this summer. And again, we really want to thank GCI for being able to fund us, support us with this pragmatic study. So I'm just going to wrap up the presentation with patient-oriented care GCI Pro tool that we have developed together within BC Cancer. And this particular study received research challenge research grants within BC Cancer for the efforts of our nurse champions, Sue Gill and Jan Stewart. And the reason why we decided to also incorporate this and create this particular tool in our group was because there was a real need to develop a tool that is able to incorporate patient-reported outcomes into clinical use every day. And we felt that there were specific unique questions that gynae patients may have, which is not necessarily answered by the conventional tools that we have, such as ESAS, etc. And as we know, being able to have the patient-reported outcome questions in the clinic and being able to have intervention according to that with our doctors and nurses, there's level 1 evidence to show that that improves overall survival in metastatic cancer patients by about 6 months. So I think we really need to adopt patient-reported outcomes in everyday practice, our clinics, our follow-ups, chemo, and even web-based, so that patients can enter this from home. And we need to restructure our nursing and physician responses to be able to address them as the answers to the questions come. So that's why we formed this particular study together. So we had representatives from 6 BC Cancer centers consisting of medical oncologists, surgical oncologists, nursing representatives and managers, admin staff, technical support team, and 2 patient partners. And we performed literature review and concluded that this was a great area of need. And we selected questions and had consensus amongst all the representatives to select the questions that may be most relevant to gynae patients. So we used pro-CTCAE and functional assessment of cancer therapy ovarian to select the questions from. And they're divided into 2 sections, symptom questions and quality of life questions. And for example, we don't just ask about the pain and shortness of breath and so on. We would love to ask about ability to work, ability to get around by self, and coping strategies, and etc. So I just wanted to emphasize that in this particular study, patient partners are such an integral part of our study, founding members of the committee, and they had input into the format, wording, and delivery of the questionnaires in every step of the way. And our future directions are really to incorporate the patient feedback and interviews into this particular questionnaire. So we do have the ethics approved, and it's a mixed methodology to demonstrate the feasibility of implementing this in our gynae clinics and have the multidisciplinary intervention linked to the routine use. So we adopted the framework of replicating effective programs framework for healthcare interventions. So apparently this particular framework requires 4 stages: preconditions, pre-implementation, implementation, and maintenance and evolution. So we have completed the first 2 phases, and I'll just really briefly talk about that. And then we are now moving on to the phase 2 and 3 at this time. So I don't know if everyone had a chance to use POSI, but this is how it looks like. If you use an iPad to get patients' answers about questions, something like this, and then we see it on the website, something like this. So patient has either iPad or actually a website on their phone or a computer to be able to enter these answers. And then if there's a lot of symptoms, for example, here they say lack of energy almost always, or a big change from before, then they are flagged as a red or yellow across the different spectrums. So the first phase was completed in Abbotsford, and we noticed that before we adopted this particular questionnaire and nursing intervention, only 17 out of patients who had worsening symptoms received nursing intervention, either pain assessment or vitals, ambulance transfers, palliative benefits, or ACP discussions. However, when we implemented the questionnaire specific to the gynae patients and connected nursing interventions to follow the answers rather than doctor's orders, we saw that the intervention amount went up to 50%. So that was successful, but the problem is what happened to the other 50% of patients who requires intervention and didn't receive it. So we sat down with our nurses and had a focus group to ask some questions about what to do. And then their response was that, number one, it is a really great tool, but it increases the workload. They think it increased the workload in a meaningful way. So it kept them busy and also gave them really meaningful ability to link with the physician and the patients. But the one big issue is certainly the time limitation, because there's only one nurse, then they're unable to see multiple patients in a row. Workflow issue, timing of seeing patients in respect to physicians seeing patients, and follow-up mechanism for issues that are not fully dealt with in clinic. So that may explain why only 50% of the patients were able to receive nursing intervention. So we have some follow-up plans for missed opportunities and PDSA cycle, where we are going to use the QI framework to resolve some of the issues. I went through a lot of different research, I guess, initiatives that are ongoing within BC Cancer, Gynae, BC Cancer Abbotsford, really, really quickly. And I'm really, really sorry about a lot of just talking and slides and so on. But I think at the bottom, really I want to emphasize is teamwork. Certainly it's not my work or anything like that. It's certainly all the collaborators and mentors who inspired us, and especially most importantly patients and other staff who really care for the patients and their loved ones, for the community and the staff. So that's sort of what our makes our research go on today, and makes me really feel engaged in the gynae community. So really want to thank everyone for listening to my talk today, and also Joni's, and welcome any questions. Thank you.